everything is present. It's regular, everything's present. The PR interval is greater than that 0.20. Some of you were very creative in your numbers, and some of you were very creative in what you called the PR interval. Keep in mind it's the PR interval. And then your complex is your QRS complex. So remember the numbers, 0.12 to 0.20 is a PR interval, which is normal. And then your QRS is 0.04 to 0.12. So please reiterate that or review that, because you will see ECG strips throughout the rest of the semester, definitely on the final. Also, when you can't measure a PR interval if you don't have a P wave. So some of you use the words, well, I don't have a P wave for AFib, for example. There's no P wave, but what's in place of it is the quivering or the fibrillation, is the true words. And when we're talking about the atrial fibrillation, it's those sawtooth or picket fences that are present, which look like, of course, multiple P waves, okay? So just to clarify that. So flutter waves, sawtooth, just some of the words. 3 or more PVCs is VTAC, ventricular tachycardia. Remember, ventricular tachycardia is a lethal rhythm. So when we think of lethal rhythms, we should automatically think VTAC, VFib. Also with PAD, what you're gonna see is unequal peripheral pulses. So just wanted to reiterate that. If it's the venous side, they will have diminished pulses, and usually the diminished pulses is all based on the edema that's present with venous, peripheral venous disease. With arterial disease, peripheral arterial disease, keep in mind it's because of no blood flow getting down, so they will have no pulses whatsoever. And then verapamil is a what?
Calcium channel blocker.
It's a CCB. And what should we monitor for CCBs?
Blood pressure, heart rate.
Blood pressure, heart rate. So your CCBs, your beta blockers, your ACEs, your ARBs. Definitely a good rule of thumb is blood pressure and heart rate. Doesn't matter about respiratory rate with those side effects. Okay, that is housekeeping. So done. Now we can start our 2 chapters. These 2 chapters will go fairly quickly. A lot of this is, or should be, reviewed to them a certain extent, hopefully. So we'll just hit some key points as we go along. And like I said, we'll cover these 2 chapters this week, and then next week is a copious amount of chapters when we go into then for fall break, and then we will have our exam when we get it. Okay, so chapter 54 talks about renal disease. First and foremost, the most important thing to remember for the most part when it comes to renal disorders is the conservation of potassium. We already know when we started way back when that K kills, so too high or too low. So with that said, when this patient is conserving potassium based on their renal status, we have to worry about, of course, the patient's potassium status as a whole, because K kills. So some of the causes of acute renal failure are listed there for you. You have to remember when we're talking about renal disease, the kidneys like blood. They do not like blood under pressure, and they don't like less blood. So when somebody is hypovolemic, they're not going to be happy because they're not getting the blood they need. Plus, they don't like the blood under pressure. So with that vasoconstriction idea. So when we're talking about hypovolemia, hypotension, is where we see the acute renal failure. Also, obstructions in the renal arteries or veins. That's all based on your atherosclerosis. So the cholesterol or lipids that are filling that area, causing just usually from that patient who has a coronary heart disease or coronary artery disease. When we're talking about chronic renal failure, that's where we see hypertension. So that's where the hypertension comes in. Again, with that blood under pressure and those kidneys are not happy with that as a whole. And some other things that will definitely cause the chronic. When we see patients who are pre-renal disease, that is your heart failure patients. That is pre-renal, so it goes to acute. Usually by definition, anything over 3 months is considered chronic. So acutely, you may definitely see that pre-renal would be that heart failure. So renal failure as a whole, algolaria, which I know I say funny, so I will spell it. It translates to medical terminology as ugly urine. Goodness gracious. Algolaria, which again translates to ugly urine. So that is one clinical manifestation of renal failure as a whole, signs and symptoms. What is the drug when a patient is going to get a IVP procedure that we could renal prep them for 3 dosages in a 24-hour period? What is that drug that's used as a renal prep? I passed it around in farm and it smelled like rotten eggs. Does that help?
Yeah.
Remember the smell? Yes.
Yes.
Mucomist is the trade, and I will spell and write it on the board for you for the generic name, so you all have it. So that's a generic, and then Mucomist. For those of you who had me in farm in the auditorium, it was hard to pass anything around in there, so. But for those of you who had me in farm in the auditorium, I'm more than willing to share that smell with you after class. Okay? So Mucomist. So remember a couple of things about Mucomist. We said in this case it's a renal prep. That means that if I have to give a patient IVP who also are showing signs of renal insufficiencies or have some suspicion of that chronic hypertension that has had, or diabetes for that matter as well, then we can renal prep them. So they would get this orally every 8 hours times 3 dosages for a 24-hour period, and then the next day they will go ahead and have their IVP contrast dye procedure, whether it's cardiac catheterization, CT, MRI, anything with contrast that they would need. And the goal is for this particular medication as a renal prep is to protect the kidneys from lactic acidosis, which is immediate renal failure. Okay? So when you have lactic acidosis, you have that buildup of lactic acid, causes them instantaneous renal failure on hemodialysis kind of scenario, which I'll talk about as we go along. Okay? Keep in mind too, there's 2 other uses for our Mucomist friend. What are the other 2? It's a mucolytic, so it breaks up the mucosa. We give that in a nebulizer. And then there's one more that we use it for. It's an antidote to something. That's my hint. For overdose of something. Acetaminophen overdose. Yep. And that's given IV. So in this world of renal prep, they drink it. Okay? And they, yes, can still kind of smell the scent of it. When it's in a nebulizer, that oxygen dilutes it so it doesn't smell. And then of course IV, they're not going to smell anything because it's in their IV bag. And it's a continuous infusion to protect the liver from that acetaminophen. Usually when a creatinine is about 2.3, they start using this renal prep when showing signs of, again, renal insufficiency as a whole. So assessment of these patients, all of which are standard for really every patient. One thing that we think about with our renal failure patients is shortness of breath, that fluid overload scenario. And then why they're having that shortness of breath for that assessment-wise of overload. Diagnoses are listed there for you. Complications with patients in renal failure as a whole. One of the things that you will also see is not only to mention all of this, but anemia, specifically iron deficiency anemia. So if you know anything about iron deficiency anemia, two things that happen with them commonly is shortness of breath and fatigue. So that is a common two symptoms for somebody who is iron deficient, okay? The other thing that we see when it comes to this whole bone disease and calcifications, this is because of a decrease in calcium. We had said when we were talking about in the beginning of the semester hypoparathyroidism or low calcium levels, where we have the low calcium and the high phosphorus. And there's medication that we can give these patients with meals because it binds with the phosphorus to bring it low, right? So in turn, if we're bringing phosphorus low, we hope that then, right, the calcium is raising. So the drug of choice would be something called Foslo. It's unique. Don't have to memorize this, but this is just a unique dosage. 667 milligrams of a medication, which is just unique because you don't normally see that odd number kind of thing. Sometimes they get it twice, 2 tablets, 3 times a day, again with meals is the goal. And that's why they like to give it with meals, is because of that binding sensation thought process with bringing down that FOS and raising that calcium. Because it is bone disease, they're more fragile, and then of course with breakage and things like that. So our plan with the renal failure patient as a whole is one thing that our goal is to get them hemostasis, right? Getting that potassium to leave, and getting them back to less complications. So one thing that we can do is hemodialysis. Not specifically us, but of course the hemodialysis nurses, unless that may be you someday. 2 things with hemodialysis. The patient has to be hemodynamically stable, because what this hemodialysis does is it actually pulls off that excess fluid this patient has. So you have to have a baseline of what the patient looks like pre-hemodialysis. The 2 devices that we use for hemodialysis is our AV fistulas and AV grafts. AV fistulas, remember, is a vein and an artery that is sutured together, okay? An AV graft is a synthetic tube that connects the artery and the vein together. Patients who have poor vessels, because of diabetes, because of smoking, because of small vessel disease, for whatever reason, these patients more than likely won't be a candidate for a fistula, because they have to have healthy vessels in order for those vessels to get sutured together. The problem with the AV graft is it's a synthetic tube, like I said, or a synthetic graft that platelets love to stick on. So when I'm assessing either a fistula or an AV graft, what am I assessing for? Prill is one, and so I'm going to feel a thrill, right? And then I'm going to hear a what? Brewing. Yep. And so that tells me what? It's patent, right? That's what we want to hear. If we don't feel or hear, that means it's not. Okay? So in the dialysis world of hemodialysis, then, this is just an animated picture, and I think it's a great visual to see what is happening, going on with that hemodialysis. The arterial blood's coming out, blood pressure monitoring and all that kind of stuff, goes into the dialysate, and then it comes back out, cleaner blood, going back in venous side, okay? So it is continually being exchanged, and that's the proper words with hemodialysis. So if you are that nurse receiving the patient that has come back from hemodialysis, if you work in a facility that has hemodialysis in a different unit and you're bringing that patient back, one thing is that you will find out is during the exchange how much fluid was taken off of that patient. So whether it was so many liters, 1, 2, 3 liters, depending. Now if it's an emergency situation where the patient needs hemodialysis because that patient's potassium level is elevated, there's other things we do. We give K-oxalate, we give them D50 with IV regular insulin to push that potassium back in the cell. But the ultimate goal is really truly to have them have hemodialysis to pull out that excess fluid. A lot of times we see exacerbations of our patients when fluid overload with renal failure is the times during a lot of family reunions, a lot of picnics and stuff in the summer, and then holidays. Because they're not following their restriction, not following their fluid restriction, not following the salt, all of that kind of stuff. So when patients are also in the verge of not knowing if that hemodialysis is going to be permanent or not, before they get that AV graft or AV fistula, they get something called a permacath. And this is just a picture of what a permacath looks like. You have a venous and arterial side and where it dumps. Even though it's called a permacath, it's not permanent. It's patients that get into fluid volume overload, maybe in an ICU, their renal system is not happy for whatever reason, and well, could be multiple reasons, and so they need to be on temporary dialysis. Then once they have either one progressed to needing more routine hemodialysis, that 3 times a week scenario, right? Tuesday, Thursday, Saturday, or Monday, Wednesday, Friday, then this particular catheter will get pulled, and then they will get the device of hemo of the AV fistula or AV graft for more long terms. So here's just pictures of what we mentioned earlier. Another type of dialysis is also known as CAPD. So it's continuous ambulatory peritoneal dialysis. So these truly are not somebody who can sit there for the 3 to 4 hours it may take to do an exchange, that Tuesday, Thursday, Saturday scenario, Monday, Wednesday, Friday, where these still lead an ambulatory life. Okay, where their kidneys are just not ready for that hemodialysis. Not yet. They're not bad enough yet. However, these patients still work. You may be walking in Walmart next to somebody who has PD going on and you wouldn't even know. Okay? You would have no idea. We had an administrative assistant here for quite a long time. She retired and now she's since passed, but she was a CAPD patient and she would leave out lunch and go and do an exchange. So let's talk about CAPD. One, important points. Now, this is kind of a not true little picture here. When the catheter goes into the patient, there is a tube that goes for indwelling and then a port that goes for outdwelling. So that's a little bit misleading. But it's a tube that comes out, you connect, and there's an indwelling and an outdwelling. That's what we do for exchanges with the CAPD patients. We indwell to outdwell. Okay, those are the proper words. One thing is this dialysate that is going into that patient. The patient will do their exchanges every 6 hours is common, unless they're on Prisma, which we'll talk about that in a second. So what we need to make sure is, because bedside nurses can do this, is we need to make sure that we have weighed and examined this dialysate. Because we have to make sure that what goes in comes out on the outdwelling portion. Does that make sense? Right? We don't want an imbalance of intake and output. We always think of intake and output as oral and then urine out, right? Or JP drains. It's the same thing here. If I'm measuring then that's 15 mLs, when I outdwell in my next 6 hours, I need to make sure that my outdwelling bag has that at least 1,500, if not more, which we're hoping for a little bit more, because you want to pull whatever excess is there, depending on what they've eaten, sodium intake, etc., etc. So we indwell, takes a few minutes. So now it goes into their abdomen. It literally, as you see where the catheter is, I'm going to say the word swishes. It swishes around that abdominal cavity for that 6 hours. Then we hook them back up. We outdwell first. With that outdwelling bag, you don't put it on the bed or on the floor. You want to make sure you put it on something that, in case it leaks for whatever reason, never put it on the floor. And the reason why is because the cooties can have a way back in, right? It's got a direct line. When I say cooties, I also know and mean that this CAPD has to be done in a very, very clean environment. this is not a household that has multiple infested animals, there's fur everywhere, there's whatever else everywhere. So they may not be a candidate for this strictly because it's as close to medical asepsis as you can get when you're doing these exchanges, okay? So as close to it as we can get. This is not where the dogs and cats run all over and whatever other pets they may have, okay? With that said, with the outdwelling drainage, you need to make sure it was as clear as what you put into the patient and it's as clear as it comes out. If there's any color change, any sediment, anything, I'm gonna say abnormal that wasn't clear like it was before, that means there's something going on in that abdomen. More than likely an infection. Peritonitis is the worst infection a patient can get in the abdominal cavity. If that's the case, and they do have some sediment and discoloration, we let the physician know. Of course, we'll check white blood cell count. But we can actually give anti-infectives right into this bag, and so when they indwell the next exchange, swishes around, it could take care of those microorganisms, or cooties, as I like to say, that are in there, okay? Other thing is the catheter gets a cap on it. Used to be betadine, now it's chlorhexidine. But we really try to make sure that we wear a mask with it so we're not giving any of our cooties to them, and of course gloves. Don't have sterile gloves on. We want to keep it as medical asepsis as you can. Notice I didn't say strict, I just said medical asepsis. So strict asepsis, of course, would be sterile world. The cap definitely needs to be, and it just screws on to their catheter. So it swishes around for those 6 hours, and then they come back. We outdwell to indwell, 6 hours. Excuse me. And we go through that whole process again. Okay?
You said the fluid is staying inside of them?
Yeah, it swishes around. Swish, 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 swish,
How
swish.
much fluid is it typically?
Well, we hope that it's at least 1500 mLs.
1,500.
Now, don't write that down. It could vary. Maybe the physician,
Okay.
it's a bigger patient and they want 2,000.
Okay.
So it's routinely,
Okay.
those bags are usually about 15 to 2,000, depending on the patient.
Okay.
And we hope we at least see that in our outdwelling.
Okay.
A lot of times, you know, the meat scales that I know every parent or grandparent have this in their house.
Yeah.
Where you weigh before you made the Tupperware and you made your hamburger press, or am I dating myself? I'm probably dating myself. But the little meat scales that were home is a lot of times what patients are also trained to do is, unlike us, they weigh them. So when they have their outweighing bag and you cap it off and all that, you weigh that to make sure it's the same weight.
And every 6 hours.
Every 6 hours. Yes, and this is, like I said, somebody who is still living a normal life. Now, there's other things that happen. Some of them don't do their exchanges during the day. They will go home and all night long, they're running the CAPD, okay? That's one form of Prisma. There's another form that's 24 hours. I'm probably gonna date myself again, so that's okay. So, do you remember, I should have a picture of it, in the 80s, now I'm really dating myself, because some of you probably weren't even born yet, but you may have had a toy that came later. When you pulled the cord, you adjusted like it was a cow sound, a pig sound, and the arrow turned and you pulled the cord. See? Okay. So that thing looks like what's on a Prisma machine. Whereas it's indwelling and cycling, I should say cycling, that arrowy thing, it's not going to cows or pigs or not mooing and not oinking, but it's spinning that fluid for that 24-hour cycle. Does that make sense?
Yeah.
Okay. So, with that said, the reason why a patient would be on a 24-hour peritoneal dialysis, we wouldn't call it continuous ambulatory because they're not. These are patients who are not hemodynamically stable in an ICU. So if ever gone past an ICU and you've seen that kind of a machine that has that arrowy thing circling, that's more than likely a Prisma machine.
Wait, isn't the same thing as CRRT?
Huh?
Is it the same thing as CRRT?
Not really. Yeah. So that is to pull off the fluid and exchange, and for the kind of wash them out or clean them out however way you want to by pulling the toxins out. pulling the toxins out is the goal. That's what hemodialysis is all about. Because remember, it's acting as the kidneys. For whatever reason, the kidneys are no longer working for whatever reason with that case. Okay? So, talking about now dialysis, oh, here's just a side view. So you see the swooshing. Of course, it's not moving, but if I was to do this, there'd be waves in that solution. Okay? But a patient, now going back to the thought of hemodialysis, where the patient is getting dialysis and needs it, maybe it's a Monday, Wednesday, well, today's Wednesday, right? So maybe they need, they are having their insulin today, or not insulin, where did that come from? Dialysis today, and we need to figure out what time, because we work at a facility that doesn't have an inpatient dialysis. So we have to wait for them, for the nurse to come in, or the dialysis tech, depending, or both, come in to do their hemodialysis. So I have a patient that's in room 24, and I need to know when, and I'm starting my shift at 7 a.m., I need to know when that dialysis is planned. They will call us and say, hey, I will plan to be there at 9 a.m. So what this bolded statement, my least favorite word of antihypertensive, but blood pressure lowering agents may need to be held so it avoids hypotension. So if they're coming at 9 o'clock and that med is due at 9, you have that window 30 minutes in, 30 minutes after, you would not necessarily give them unless they tell you to. Depending on what, they will ask questions like, what has the blood pressure been overnight, and then this morning, things like that. If the patient's dialysis wasn't coming until 1 o'clock, you can definitely give those meds at 9 o'clock. Because you don't want them to have a stroke, or stroke out, or throw a clot by the time you're waiting for dialysis to get here. Okay? But if it's going to be early enough at the same time that the dialysis is coming, and when the blood pressure lowering agent is due, then we don't want to cause and avoid hypotension, because by them pulling off that fluid in hemodialysis, that blood pressure will lower anyway. That is the goal, right? Along with the potassium and all that. But dialysates can be made up of different stuff. Biphosphates, other stuff that what the patient needs based on what their lab showed, things like that. So, and it could be specific to that patient. It's not homemade, but it's different types that can be used, whether they have to have this kind of wash and that kind of wash, etc. So, depending on the timing of those blood pressure lowering agents are everything. Meticulous skin care when it comes to patients that have renal failure. One of the things is, with dialysis, the dialysate can cause itching. It's just a common side effect. One thing we could think about doing is giving some kind of histamine to help. But the basic thing we can do is make sure that the nails are trimmed. You know, we don't go a nail clip anymore, but if you have those disposable nail files and you know your patient's going to get dialysis and you know their skin's going to itch, then you could always file them down. Nothing wrong with filing, we just can't finger clip them anymore. So we don't want to introduce a risk for infection because of impaired skin integrity on top of all this world. Okay? Questions about hemodialysis, CAPD, Prisma, any of that?